name is Wade Colburn, and I am the product manager here at Cochlear, responsible for nucleus cochleus implants. Today I'll be talking to you about surgical outcomes and this question of does placement within the cochlea matter? Before I begin, just a few disclosures. So I do work for Cochlear, and I have a biomedical engineering background. So this question of does placement impact performance? For this session, I sort of am taking a look at it from a historical perspective on how placement and what's in the literature ultimately impacts our performance of our recipients of cochlear implants. So one of the things that is, from a predictors of good CI performance and whether or not this notion of placement really matters is to take a step back at one of the biggest studies that we've seen within our industry, which many of you are familiar with, the Blamey and Lazard studies, as well as the Holden studies. And what these two looked at was basically assessing how the different factors that can influence cochlear implant performance. So in the Blamey and Lazard paper, they looked at 15 different centers and over 2,000 patients and really honed in and did an analysis on what are all those different factors, both patient and design factors, that can impact the overall performance. Out of these, both the Blamey, Lazard, and Holden paper came 4 key patient factors and 4 key design factors that we'll take a little bit closer look at. So from a primary patient factors that sort of rose to the top, the first was duration of hearing loss, age at implantation, age of onset from severe to profound hearing loss, and then etiology. So we recognize that these probably don't come as a surprise. These are factors that we throw around in the industry a lot. But we also recognize as a company, and these are obviously still important, but as a company we recognize that the design factors and how we design our electrodes also influences that overall performance. So while these 4 patient factors are extremely important, we also believe that the 4 design factors are equally important. And that those 4 design factors are the greater number of electrodes within scala tympani, absence of translocation from the scala tympani to the scala vestibuli, a not excessively deep insertion, and reduced distance to modiolus. So these 4 design factors were pulled out of those papers and really shown that that these had the greatest influence of other design factors and other factors. And so today I'll really hone in on 2 different areas. One is the absence of translocation from scala tympani to scala vestibuli and the importance of scala tympani placement. And the second is the overall reduced distance to the modiolus. So first, let's start with this, the importance of scala tympani insertion and what the historical literature tells us about this. So the first question related to this is, does the electrode design itself, on whether it's a paramedialar array or a lateral array, impact the overall electrode placement into scala tympani? And so there was a study that was done by O'Connell that basically looked at a bunch of other studies and sort of compile those all together to really look at this very question. And what it showed was that there was a higher significance or higher chance of scala tympani insertion with those lateral wall arrays compared to paramedialar. So typically we would see in that literature the high 80s to mid 90s in terms of percentage of the time that you'll be in the scala tympani with a lateral wall, whereas those pre-curved arrays of both the contour advance and the mid-scala electrodes had lower rates of scala tympani that were anywhere between 40 to 70%. So we recognized out of that the historical evidence suggests that the pre-curved arrays may be less likely to be placed in scala tympani. So this is important an observation, but the question then becomes is, how does the surgical approach also impact the electrode placement? So when I say surgical approach, we're talking about extended round window versus cochleostomy. And so there was 2 studies that looked specifically at this question, and they really showed that round window and extended round window had a higher percentage of scala tympani insertions compared to cochleostomy. So those rates were in the 80s, 70s to 90%, whereas cochleostomies showed with in the range of 30 to 40% of the time where they were in scala tympani. And this was not just with a certain type of array. This was with both paramedialar and lateral wall arrays. So it begs the question of, okay, why is cochleostomy seeing these types of numbers? And the likely suggestion of this, which Dr. Briggs as well as Dr. Buckman have done work on, is this inconsistency of where do you place the cochleostomy. And there was a specific study from Briggs et al. Back in 2005 that showed that there was an increased risk of scala vestibuli insertions when the cochleostomy was placed anterior to the round window compared to inferior to the round window. So with the extended round window and round window insertions, it might be a little bit more straightforward compared to the cochleostomy overall placement. So from this historical literature, we showed that extended round window and round window may lead to more consistent scala tympani placement. So we've looked at the way the design might impact, we've looked at how the surgical approach impacts scala tympani, but the question then becomes is, okay, if you're in the right scala, does that actually lead to overall better performance? And the question there has been well studied across multiple studies over the last 10 plus years. And in that same article by O'Connell, they looked at a range of studies and a range of participants, and out of that it showed pretty compelling evidence supporting significant performance increases if you were in the right scala. But while that is intriguing, there was a more recent study that was looked specifically at the contour advance electrode and comparing how the performance differs between scala tympani, scala vestibuli, or a translocation. So in this paper out of the University of Melbourne, they took contour advance, 57 contour advance patients that were all postlingual, and they matched the groups. So essentially the age of duration, the age, the deafness duration, as well as the pre-op phoneme scores were all non-significant. So they matched them so there was no significant difference between those. And then they took a look at how the patients performed at 12 months relative to if the electrode was in the scala tympani, the scala vestibuli, or there was a translocation. And in the scala tympani arm, they showed 69.1% in terms of phoneme scores. Scala vestibuli was 54.2, whereas translocation population was 50. And so this showed a significant difference at that 12 months that once again proved that scala tympani placement does significantly impact patient performance. So now that we've looked and proven that scala tympani placement does in fact matter, let's look closer at another design factor that was identified in those Blamey and Lazard papers, and take a little closer look at that. So this specific one that we'll look at is this reduced distance to the modiolus, and the importance of how medallar proximity can impact that overall performance. So you might be asking yourself, well, how can I determine where the electrode is placed relative to the modiolus? And so there's a few different academic institutions that have been able to develop a method in order to understand that. One of those being Washington University, where they essentially take a 3D reconstruction, do some different measurements within that, and can create what they're calling the wrapping factor. And essentially that calculation corresponds to, you take the length along the electrode and then divide it by the overall lateral wall length. And so essentially, to kind of put this in perspective, a wrapping factor of 100% would essentially mean that your array was completely along the lateral wall. So the number would be the same between the length along the electrode over the lateral wall length. So previous studies relative to the wrapping factor have reported that a lateral wall electrode doesn't quite go all along the lateral wall, and so the wrapping factor is typically around 80%, whereas a paramedallar array is around that 50-60% range. And so you might be wondering, okay, well, why is this important? Well, they can take this wrapping factor and then compare that to the overall performance scores and see a trend. And the trend has been largely that as you get a tighter wrapping factor or become closer to the modiolus, that you actually improve the overall performance. And so that study was done by the Holden paper and really proved that there is some benefit to being closer to the hearing nerve. So this graph shows that very trend of that as you become more paramedallar, you are increasing the overall performance. But I will note that you are seeing some variability even with in this specific study. It was all contour advanced, and so you do see some variability in wrap factor, which I think will become important a little bit later in this talk. The other piece to kind of call out, though, on, okay, we're seeing improved performance, but what else are the potential benefits? And so in the Polanenko paper, they looked at, focused stimulation and how that leads to lower current levels, to elicit neural responses. And then the Hughes paper, showed that being more medallar hugging or paramedallar actually reduced the channel interaction. So you're getting more focused stimulation, you're having less to do or less to manage from a threshold perspective and less current levels, and then we're seeing just an overall performance benefit as shown in the Holden paper. So out of those studies, there's real support that there are programming and performance benefits with a paramedallar array. So we took a closer look at the importance of electrode placement from a historical perspective, both for scala tympani and proximity to the modiolus. But more recently, this very question was actually asked in publication from Vanderbilt of, does electrode placement matter? And out of their study and doing similar analysis on all the different factors that can impact that, they concluded that there was significance of electrode positioning and overall audiological outcomes. And coincidentally enough, the most significant positional predictors of outcome for a pre-curved array, like the paramedallar array, were scala tympani insertion and the medallar distance. And so earlier I alluded to the fact that we've proven across multiple studies that these two things are extremely important, and and over the years it's become more and more evident. But I think the missing piece was, can you do that consistently? So can you be in the right scala consistently? Can you be close to the nerve consistently? And I think largely the answer was, it depends. It depends on the surgeons, it depends on the center, it depends on just a number of variabilities. And so as Cochlear, we really took a look at that and said, how can we refine and make sure that our electrodes are becoming more consistent, where regardless of where it's being implanted or what patient it's being implanted into, that we can in fact get consistent scala tympani location as well as consistent proximity to the modiolus, so we can prove that there is that added benefit. And so with that in mind, we essentially took what was great about the Contour Advance and made it even more consistent and created the CI532 or slim medallar electrode, which is our latest electrode offering. And so, when we look at that specific electrode, there was kind of three kind of main things to call out and focuses from a design perspective. It was looking at preservation, and how we can design a very thin atraumatic electrode that's thinner than any array in the marketplace, and then also looking at placement when we look at consistent scala tympani placement and ensuring that we're getting there at the levels that we had seen historically for the lateral wall, but then taking all that and getting a thin and consistent scala tympani, but then saying, how can we get it closer to the hearing nerve and consistently close to the hearing nerve, and see that those benefits that I had shown, where you get more paramedallar and you're increasing the performance. And so with the 532, we've been able to get closer to the hearing nerve, and we're going to continue to see how that adds in terms of overall patient benefit. And then the final thing was, from a preference perspective, ensuring that with our Contour Advanced electrode, we could only really go through one surgical approach, whereas now we can insert it via all three surgical approaches. So this is really what our design goals were with the 532. And the key of this is that we do believe that placement within the cochlea does matter, and I think we've shown that from a historical perspective. But then now with the introduction of 532, we believe that this can become even more relevant. So we're going to be closer to the hearing nerve than ever before, and do that consistently. And we're going to consistently be in this right scala. And I think we can all agree that based off this literature, that it's expected that our patients are going to continue to do better, and that 532 is sort of that next step in terms of how our patients can continue to do better. So with that, thank you for your time, and it's been a pleasure to kind of talk you through why we believe at Cochlear that placement within the cochlea does matter, and that's placement within the scala tympani and placement close to the hearing nerve.